Hello, everyone. Good afternoon, and welcome to our meeting on self-monitoring in the regulation of social services. I'm Ilad Olev, head of the quality assurance team at Myers JDC Brookdale Institute, and I'm very happy to host this event. In our meeting today, we have a special opportunity to meet representatives from regulatory bodies from 3 different countries, Israel, England, and Ireland, and to explore together the topic of self-monitoring, policies, practices, benefits, and challenges. And before I continue, I just want to say something in Hebrew for the translation, so excuse me for a minute. שלום לכולם, לכל המשתתפים, מי שרוצה לראות כתוביות בעברית תוך כדי הוובינר היום, צריך פשוט למטה להפעיל את הכפתור של הכתוביות למטה. אתם רואים את זה למטה, הכנו שקף במיוחד בשביל זה. מי שמפעיל את זה אמור לראות את הכתוביות תוך כדי באנגלית. תודה. So, self-monitoring means that the service assesses itself against the required standards. During COVID-19, in a time of which a lot of the inspection is done remotely, this gets a new meaning. So let's start, and we'll begin with greetings from 3 people who supported this event. First, I'd like to invite the executive director of our institute, Professor Michael Hartan. Michael, the floor is yours.
Thank you, Hila, and welcome everyone. It's a pleasure to be here with everyone today. I just want to say that it's a very exciting meeting for us to have the representatives of the Health Information and Quality Authority, of the Care Quality Commission, and also of the Israel Ministry of Welfare and Social Affairs. It's very exciting, this concept of exchange of ideas, of best practices, the ability to so quickly and easily transfer information and knowledge and learn from the best practices, one from another. I would like to point out the strong partnership with the European Social Network, who really helped us make some of these very important connections, and to thank Alfonso Lara Montero, the Chief Executive of the European Social Network, for being here with us today, and Tanya, who does a tremendous amount of work in helping us connect and collaborate with partners around Europe. And so, again, we're very excited that this is yet another step in our ongoing collaboration with the European Social Network. And we hope that this is next steps for additional collaboration. We have worked closely in the past with the CQC, and we hope that now that we have the opportunity to do work with the Health Information and Quality Authority in Ireland, that we'll continue to expand this network, which we do in order to help bring more knowledge and best practices to Israeli society, and specifically to the government of Israel and the Ministry of Welfare. So I also would like to acknowledge the senior representatives from the Ministry of Welfare that are here with us on the call today, and to thank them very much for their participation. I hope that we all have a very productive time on the webinar today, and I look forward to learning with everyone. Thank you, Ila.
Thank you, Michael, very much. Thank you. And our next speaker will be Alfonso Lara Montero. He is Chief Executive Officer from the European Social Network. Our institute is a member of this network, and we find it helpful in many ways, including in organizing this event. So, Alfonso, the floor is yours.
Hi, good afternoon, everybody. It's a pleasure to be with you, with the Myers JDC Brookdale Institute. Actually, as you say, you're a member of the European Social Network and also the Ministry of Welfare in Israel. And it's a pleasure for us to be able to share this time with you, and also to see that the Health Information and Quality Authority of Ireland is a member of ESN, is part of this meeting, as well as the Quality Care Commission in England. It's also an organization that we know well and we've cooperated in the past. I'd like to maybe start with some reflection around what we mean by assessing quality. This is obviously for us a very important topic because we've worked on this over the years. When we look at the assessment of quality, is something that we understand as a journey. And we've worked on this over a number of years. As I say, back in the year 2010, we produced the first report specifically on quality of social services, looking at long-term care and the relationships between the providers, public authorities as funders, and people in what we called contracting for quality. Then later on, around the year 2018-19, we had a number of events where we tried to analyze better what we meant by quality, particularly at European level, and try to promote that the European Commission works with the national governments to promote a common understanding of quality. And this is what you see on the screen, striving for quality, is the actual outcome of that work. And in 2021, we produced Putting Quality First, where we actually looked at the role of public procurement, contracting publicly, as a way to actually secure quality in social services. Now, if we move forward, we can look at assessing the quality of services in two different ways. On the one hand, or as we understand it, on the one hand is the question of assessing the quality of the system of social services. And there you've got, on the one hand, the area around legislation, rights. So what are so social services are supposed to actually ensure that social rights that are conferred by legislation are actually implemented in practice. Then you've got the economic relevance. So what are the investments that governments are making in order to ensure that those rights are actually implemented in practice? And the third element is coverage, is how those rights are actually covered through a set of services. Because of course, we cannot talk about quality without ensuring that services are available for the population as a whole. The second element of quality, of course, or the second way of understanding quality, is actually looking at assessing the quality of social services programs. And there, when we look at assessing the quality of social services programs, the first thing that we need to look at is what is quality. And surely today we will discuss what we mean by quality for the person in the first place, but also for the policymaker, for the director of services, for the provider, and very importantly, for those who are responsible to ensure that care quality is observed, and that is for care inspection and monitoring and improvement agencies. Now, one thing that is very important is to look at who are quality principles for. They are surely for those who are responsible for planning, for financing, for regulating, for providing, for people themselves. But what about when people become commissioners of their own care? And this is actually very much relating to the question of self-monitoring. And this is the reality we are facing now. And this is why we keep on working with the European Commission and national governments to move just from the idea of quality assessment in terms of processes, outputs, inputs, but also moving towards outcomes. What is the real impact of those services in people's lives? This is what quality certainly needs to look at as well. And what are the building blocks of that quality assurance? On the one hand, of course, we've got person-centered services. We've got transparency. It needs to be clear what are those, how quality is measured for people themselves. What about regulation and governance? What role do they play? And certainly quality inspection agencies are key in this process. I mentioned earlier on our work on public procurement and commissioning, how we can use public contracting of services as a way to ensure quality. And of course, these days, we can't forget about technology and data, how actually technology can help us improve quality of care and social services. And then we move on to how do we measure quality? On the one hand, we can look at client satisfaction, person satisfaction, but what about improvement and monitoring? So how do we ensure that we have improved people's lives with those services is the key question with which quality is obviously concerned. Another question is how do we move from here? So how to measure quality improvement from the perspective of the person, but also how to measure quality across all settings, not just, let's say, when we look at long-term care in nursing homes, but also in people's homes. And how do we ensure that we are supporting people's well-being? How do we ensure that the leadership is taking care of ensuring that quality of care is there? How good and how supportive are staff and how supported are staff to be able to provide quality care? What about the settings where this is provided, regardless of whether it is nursing homes or people's homes themselves? And how well is care planned and what is the capacity for improvement? Those are questions that certainly are very much in relation to how we monitor and how we improve quality. So I hope it will be a very fruitful discussion. I hope this has opened some of the key questions that you are going to be discussing today, and very much look forward to the conversation.
Thank you very much, Alfonso, for bringing us the ESN perspective about quality monitoring. And now I'd like to, our next speaker is Nir Kedar. He is a Deputy Director General and Head of the Administration for Strategy, Economic Planning, Research and Regulation in the Ministry of Welfare and Social Affairs in Israel. Actually, the ministry initiated this event as they are now in the process of updating their overall regulatory strategy. So, Nir, the floor is yours.
Thank you very much, Hila. I would like to begin by thanking the organizers of this important meeting at the Ministry of Welfare, the European Social Network, and of course, the Brokdale Institute, our partners. In the ministry, we see great importance in advancing the field of supervision and control. In the last 4 years, the Ministry of Welfare has undergone a process that on the axis of revolution and evolution. We consider it very important to develop tools for supervising and control of social services, and we must invest a lot of resources in this regard. From my knowledge with other social systems in Israel, I can say with confidence that the tools that stand in the welfare system today are among the most advanced in the Israeli social services, and still we have much of place to improve. This meeting is very important to us. We want to hear and learn about what is happening in the world and also get feedback on the steps being made in Israel. The field of self-monitoring received a significant leap forward the Corona period and is now required all of us to continue to squeeze the lemonade from the lemon. The aspects of regulation, strategy, practice, benefits, and challenges are all important, and we have a lot to learn and develop all of them. We are very grateful to everybody attending this meeting and will be very happy to continue and hold more meetings later. I will end with my opening sentence. Thank you very much to all the organizers and participants, and I wish all of us a fruitful meeting. Thank you.
Thank you, Nir, very much for initiating this event. And I'd like to introduce the presenters that are with us today, who will present their perspective, their regulators. So from the Care Quality Commission, CQC in England, we have Dave James. I will give some details before the presentation, more details. So say hi, Dave.
Hi, everyone. Thanks very much for inviting me. Just to say, Hila, I know I said I was squashed on time for today, but actually my other appointment is now cancelled, so I'm here for the whole event. I'm really happy to say. So sorry to give you heart flutters over that. So yeah, I'm Dave James, Head of Adult Social Care Policy at the Care Quality Commission in England.
Thank you. Thank you very much, Dave. And from Health Information and Quality Assurance Authority Hikwa in Ireland. We have here Carol Krogan and Eileen Kin. Say hi, both.
Hi, thank you very much for having us. Lovely to be here.
Thank you.
Hi, everybody. Good afternoon. Likewise, thanks for having us. It's quite an interesting topic to be discussing.
Thank you, Carol. And from the Ministry of Welfare and Social Affairs in Israel, we have here Dr. Hila Chaim Zweig.
Hello, everybody. Very happy to have this opportunity, and thank you so much.
Thank you, Hila. And before we begin with the presentations, I would like to explain how this is going to work here now. So each regulator prepared a presentation around 3 themes. One is a background on the regulator, purpose, role, types of services they inspect. The second theme is self-monitoring, strategy, approach, tools, and methods used. And the third and very interesting one is lessons learned about self-monitoring, what works and what doesn't. Each presentation will last around 15 minutes, and then we will have 5 minutes for questions and answers. Technically, this is a webinar platform, so you can only see the panelists. You can't see all the participants. On the bottom of your screen, next to the chat, you have the Q&A button, so please feel free to ask questions. The chat is closed today, but the Q&A is open. You can ask in English or in Hebrew. We will translate, we will handle the questions. And as you can see, we also have a simultaneous translator to Hebrew with subtitles. So this is, again, another opportunity to operate this. You have to operate it with the button. Hopefully, we will have a few minutes in the end to answer additional questions for the overall presentations. So let's start now. Our first speaker will be Dave James, Head of the Adult Social Care Policy from the CQC. So Dave, the floor is yours.
Thank you very much. And I shall just share my screen. We don't use Zoom where I work, so I'm just trying to remember how to share. Oh, there we go. It's in green. Okay. Bear with me. Oops. So hopefully everybody can see my screen. So as Hila said, I'm here to set the scene really in terms of CQC's role, and then talk a little bit about how self-monitoring has worked or not in our model, and where we're going with our regulatory model, and how self-monitoring might play a role in that. So CQC is the regulator of health and social care in England. We regulate around about 50,000 services. So from the largest hospital right down to the smallest care home or dentists. And we are taking on new powers from next year to start to make assessments of local authority, local council commissioning practice and their role in delivering social care, as well as newly forming entities in England, which are called integrated care systems, which are a kind of whole population, which we formed of a number of different councils and all the health agencies as well, to look after care over quite a significant geographical area. And we'll be having a role in assessing the overarching system at that level as well. This is quite a full slide, and it's slightly out of date, but not too much that I can't speak to it. There's quite a complicated network of oversight agencies in England, and as you can see, we are over here. We're essentially an arm's length body, or what's known as an arm's length body from the government. So we have independence from central government. We are funded by the providers that we regulate. We're not funded by the government or by our parent department, the Department of Health and Social Care, except in relation to the enforcement action that we take, which does come from central funding. But essentially all our activities of registering providers and inspection and rating is all funded by the providers themselves. And I've mentioned the local authorities here who have certain duties to ensure social care works within their areas and to commission provision, and also to make sure that there's a market of choice there for the people that live within that area, so they have a good choice of high quality services. And that's part of what we'll start to look at as we look at our future, step into our future role. Just a quick word then, and I'll probably come back to it, but just to describe where we got to in terms of self-assessment in our current model. And I think the first thing to say really before I speak to this slide is, I'm sure we'd all agree that a key characteristic of a quality service, a quality provider of quality care is a provider that knows itself, is able to reflect as part of its governance and quality assurance. It understands its strengths and weaknesses. So regardless of how we require any kind of self-assessment activity or how we use that information now or in the future, that will always be a key thing that we look at in our framework. How does the service know itself? How does it learn and improve? Is it focusing on the right areas? It's a really important aspect for us to look at as part of our assessment of leadership. In terms of self-assessment, though, I would certainly say we have not cracked this at all. We've not achieved the best method of using self-assessment in our current model. We have at the moment in some of our sectors, and certainly in social care, we have what's known as a provider information return. That's a mixture of key facts and data that we need from the provider, as well as a chance for the provider to describe, as you can see on the screen, describe what is going well and the impact this is having on the people that are using your service. And we do that for a few questions, and we sort of prompt there in terms of, do you have a clear vision? How does the service continuously improve? Some of the issues with this, it's an annual return. It's not mandatory, but we do consider what it means if a provider isn't able or hasn't sent one of these returns to us. We do reflect that in our assessment in terms of kind of how, again, going back to governance and quality assurance, what that might indicate about the provider. But I think the main thing to say, even on top of those things, is our current model is absolutely predicated and based on the central role of inspection. Everything is about gathering information to take forward on an inspection and to do an assessment in a concentrated period of time. And as I'll go on to explain in a moment, we're breaking that process down and removing what we think is not a helpful step, which is information gathering, which we don't act on, which all we do is we kind of store it up and use it to consider how we go and inspect, when actually the information itself is often evidence, and we should be taking that into account as we update our judgments and maintain an up-to-date judgment. I'll go on to explain that in a little bit more detail in a moment. So I think that's the main thing there is there isn't really a clear role for self-assessment. We've not really committed to it, and we certainly want to do that as we step into our future model, both at provider and service level, but also at the local authority and at the system level as well. There's a key role there, we think, for self-assessment. So today will be really helpful for me to take back to our work in terms of how we do that and what some of the other challenges that others have faced might be. So very quickly, we are going through some really quite significant change at the moment in CQC. We are effectively changing everything, but I'm just here to talk about the future, the regulatory model. At the moment, we have 4 assessment frameworks: 2 for inspection, 2 for registration, and they're split across health and social care lines. They're really long, they're really complicated, they're not accessible. They try to be outcomes focused, but they frankly are not. And there are, across the inspection frameworks, there are 335 what we call key lines of inquiry, or CLOEs, and supporting questions. So essentially 335 questions, which is obviously not helpful to anyone, not us, not the people who use the service who need to understand what quality means in an easily digestible way, and not to the providers who we expect to monitor their own quality. I've just circled there the stage in our old model that we used to have, or we have at the moment, we've not yet transitioned, which is monitoring. So this is the provider information return coming in, other information flows coming in, and we're considering that as part of our pre-inspection planning. Then going away, as I say, a single point in time to consider what that means in line with the questions, that long list of questions. We take that away and we line that up against what good looks like and our guidance around the different ratings levels. And we have 4 of those I'll go on to explain in a moment, and publish a very quite a dense narrative report, which takes quite a long time to publish, and is not particularly structured and doesn't support us to easily pull out data and to analyze. So we're moving to one assessment framework for everything. So all those 50,000 services I mentioned, plus the local authorities, plus the integrated care systems, everybody will be assessed against the same standards. And I will go on in a little bit more detail as to how that's achievable. An ongoing assessment of quality and risk. So not separating out monitoring from inspection, but actually gathering evidence, maintaining an up-to-date judgment as to what that means about quality, using inspection as one of our tools, but not the only tool. We're starting to look at how we can use scoring to structure our assessments of the evidence, as well as to give more transparent and consistent outputs to the public and to providers. So that's kind of now and what we're stepping into. So that single assessment framework that I mentioned is here. So we are sticking with the 5 overarching key questions, and they looked a little bit like what Alfonso shared up actually, or certainly some overlap. We essentially ask at this very high level, is the service safe? Is it effective? Is it caring? Is it responsive to people's needs? And is it well led? Now, what we have done, again, going back to Alfonso's slides, talking about what does quality mean to different people, we have long been committed to being a regulator that works through the eyes of people that use services and through their families and their carers and their loved ones. And how we're achieving that in our new model is we are using a set of I statements. So these are statements that basically say, I get this, I expect that. We haven't made these up. These have been co-produced by one of our partners in the system, an organization called Think Local, Act Personal, and they have co-produced with people that have long-term care and support needs, and with a broad range of stakeholders, what good person-centered care means to them, and in plain and simple language. And that is hugely powerful, we think, and that is essentially the heart of our framework, and we've aligned that with our 5 key questions. Rather than going away and making up something which we think means quality, why not just use what people who actually are the experts have said? So that's the starting point for our framework. We then use what are called, what are essentially we statements. Now, these are really commitments that the provider or the local council or the integrated care system would make in order to deliver those I statements. And again, these are written as plainly and as clearly and as succinctly as possible to really set out so that everybody can understand what it is that you need to deliver in order to make sure that care is quality and is safe and is person-centered. And there are 32 of those, and I can flash up the topics they cover in a moment. Those 335 questions that I mentioned, we realized are essentially 6 questions that we ask over and over again. So in relation to any given aspect of quality, whether that be assessing risk or safeguarding or care planning, we essentially want to know, so what is people's experience of that? What have we heard from staff and leaders at the service? What have we heard from our partners in the system? What have we ourselves observed in terms of care delivery or the care environment? What can we learn from the provider's policies, procedures, documentation, processes, and what do the structured outcomes and performance metrics tell us? So those are the main categories of evidence. All of those 3 levels will be the same for everything that we do. That we think that's a really important thing to get across. It's built up from what people have said, and right up to the largest, most complicated care system, everything emanates from what people expect. Where it needs to get more specific is at this bottom level, where we need to be clear the actual items of evidence that line up against these categories will be very different for a residential learning disability service when compared with a dental service or a GP, a general practice doctor's service, or a large hospital, or whatever that might be. So that's where it gets more specific, and we maintain an alignment with current best practice standards and guidance. And I think just linking this to self-assessment, we think this is the kind of structure that we need, firstly, to make sure that our expectations are clear and actually support self-assessment. And they're not just a long list of questions that just leave providers scratching their heads. And actually articulating these we statements more in terms of outcomes and aligning them with the outcomes that people expect to see, we think just is a more powerful tool. In terms of where self-assessment would sit, you can see the feedback from staff and leaders category here. So we think as we develop our approach to self-assessment and what we expect to get from that, it would sit under that heading, that evidence category. Just flash this up, I won't go through it in detail. I mentioned the 5 questions that we're effectively looking to answer. And in terms of self-assessment, probably a key one might be down here under leadership, under well-led. To what extent is the provider learning, improving, and innovating? But really, self-assessment will play into all of these, and we would expect the provider or the system, whoever it is that we're assessing, to need to draw in other evidence. So they would need to be able to cite people's experience. So if they've done a survey of the people that use their service and they want to use that to back up their self-assessment, then that's really helpful for us, because it's starting to gather our evidence for us under all of those evidence categories that I just listed a moment ago. Just to bring it to life then, here is an I statement, which is one of those co-produced statements. So when I move between different services, settings, or areas, there's a plan for what happens next and who will do what, and all the practical arrangements are in place. And then what we actually hold the provider to account for, or the wider system, is this commitment here. We work in partnership with others to establish and maintain safe systems of care in which people's safety is managed, monitored, and assured, especially when they move between different services. So as you can see, we've pitched them at a relatively high level, but they're still clear, and they can be applied to any lens that we need to put on them for all of our different roles and our different areas of focus. So moving away from inspection as a set piece, as something we do maybe once every 3 years, depending on the quality and the information that we're getting about a service, we're going to break down our requirements and our timetable for gathering evidence in line with these evidence categories. So this is just an illustration. It will look different to this when we finally implement this next year. But based on different categories or families of services, we think we'll need to do things at different frequencies. So observation wouldn't play a role in care that's provided in people's own homes, in home care, for instance, in social care, but clearly has a huge role to play in residential social care. So we will tailor our timetables to the context of the service model and to what we know about that particular service as well, so we can alter in relation to risk. And I mentioned, just circling here, the category about feedback from staff and leaders. This is where we would be seeking, as well as any information that we can't get through other means, where we'd be seeking the provider's own assessment of their performance against those 32 topics, those we statements that I've been talking about. And maybe we'd want that every 2 years, maybe we'd want that every 6 months, maybe it would be different for different services. I think that was my final slide. I hope that was helpful.
Thank you, Dave. That was very interesting. I think it was interesting to hear about the changes you're doing now. and we'll be happy to hear about the implementation of this new strategy. I think the we statements are very interesting in being accessible for and well understood for providers and the public. So let's see if we have additional questions now. Talia? We have one question.
We have one question. Dave, you mentioned that you didn't yet crack the topic of self-regulation, but you did say that in the past you had reportings both of successes and challenges. Did you find any difference between the two in the motivation of the supervised bodies to share the information, the quality of information you got through those two different aspects of self-regulation?
I think anecdotally, we find that the providers that do commit to that are the better ones, and it gives us some assurance. But really, we haven't set it up in a way that maximizes that kind of analysis. I think that's part of the problem. It's hugely narrative. It's not structured. It's not outcomes focused. So we need to learn from that as we step into this new model. So I think the insight that we've got from it has been not great, and that's not fair on the providers, because if they are taking that time, there's an absolute need for us to reflect that and use that information. And I think I think we're falling short in some areas there, so we are looking to correct that.
Thank you, Dave. Thanks. And we're moving on to our next presenter. We are moving to Carol Krogan and Eileen Keane from HICWA.
I'm going to share the presentation there now.
Thank you. I want to remind again that there is a simultaneous translation. You can operate it in the CC button at the bottom of the screen. You see CC closed caption. You just have to operate it to see the translation. And if you have any questions, please write it in the Q&A.
Can I just check there? Are you seeing the full slide or the one with the notes?
The one with the notes, Aileen.
Okay, 1 second.
Yeah.
Is that better? Thank you very much. I have the two screens and it mixes up which one I'm showing. Good afternoon. My name is Aileen Keane. Carl and I are going to share in our presentation today. So I'm just going to talk a little bit first around HICWA, or the Health Information Quality Authority, who we are and some of the areas we work in. So the function of the Health Information and Quality Authority is that we are an independent authority, and we have been established to promote safety and quality in the provision of health and social care services for the benefit of the health and welfare of the public. And that's the definition as defined in our Health Act 2007. So within HICWA, we work in a number of different areas. We set standards, person-centered standards and guidance for health and social care services. So we have standards for different service types, for older person services, children's services, and disability services. We also do health technology assessment. So we evaluate the clinical and cost effectiveness of health programs, policies, medicines, medical equipment and diagnostic and surgical techniques to advise public and sort of national policy in relation to the cost effectiveness of health programs. We also work within the health information. So it aims to develop consistency and standardized approach to health and social care information, including national data sets utilized across health and social care services in Ireland. We work in partnership with our health service executive and the government in relation to carrying out national care experience surveys. So we go out to the public and we annually, we ask them about their experiences of having received hospital care. We are expanding those programs, and we've been out and asking people, women using maternity services, of their experience of using the services. And also we're looking towards maybe expanding those into older persons and people utilizing nursing homes to gather more in-depth feedback around their experience of using those services. Within the legislative framework, we have standards and regulations, but not all of the services we monitor have regulations against them. So, for example, with our hospitals, we monitor them against standards. We don't have enforcement powers where we do find there are failings. However, for the areas that we regulate, such as nursing homes, residential services for people with a disability, and for children who live in special care units, and medical exposures to ionizing radiation. So those are the areas where we do have regulation and regulations where we can have enforcement to make improvements. So within that, the Health Information Quality Authority just regulates our ionizing radiation. But within the Health Information Quality Authority, we also have the Office of the Chief Inspector, which is independent. And that's my colleague, Carol Grogan, here with me today, is our Chief Inspector. And she has responsibility for the regulation of nursing homes and for residential services for people with a disability and special care units. Again, we look at our remit is potentially expanding over the next number of months and years in relation to expanding our regulation of home care. And also human tissue bills are expected, and to increase our powers for monitoring against hospital services by increasing the notifications, the statutory notifications that providers must inform us about. So that's the areas we work in, and so it's quite diverse. So part of today, I'm just going to talk about mainly the regulation of health and or the social care services that we regulate. And across the authority, we have devised what we refer to as our authority monitoring approach. So it is a standard approach to any service that we regulate or monitor. And we've said that there's 4 elements to that we receive information. We get that through statutory notifications or when we gather information on an inspection, and that we always review the information that we receive. And depending on what that information is telling us, we will take regulatory action. And when we talk about regulatory action, we have a suite of things that we do, whether we meet with the providers to discuss the improvements they need to make, or whether we will carry out an additional inspection, or whether we will take enforcement action. And then we talk about reporting. And reporting to us is not just about the report of the inspection we publish on our website, but also about internal reporting for our own oversight of the services that we regulate, and that we can focus our attention to those services that perhaps are not doing as well. And for that element, we take a risk-based approach to regulation. And when we talk about a risk-based approach to regulation, we have defined that there is a minimal formal regulatory activity. So, for example, within our nursing homes and residential services for older person or for people with disabilities, we have said that that is 2 inspections within a 3-year registration cycle. So the registration, all nursing homes or designated centres are required to re-register with us every 3 years. So we say we will carry out an inspection at least twice within that, renewal period in that 3-year time frame. And then thereafter, we will hire where services indicate to us that they perhaps are not doing as well, or there are higher risk areas. This will lead to higher regulatory intervention, whether that is additional inspections or perhaps meeting with the provider, so that we target our resources to those services that perhaps are not doing as well, and that those services where there are good providers and are working well, we still intervene in that we do the 2 inspections, but we don't carry out any extra activity unless we feel there is information we have received that indicates we should do some extra work there. So while I did speak that we monitor acute hospital services, the services that we talked to here today under the remit of the Chief Inspector are the children's services. So that's special care units, which are centres where the courts have indicated that for their own safety, children must be cared for. We just have 3 within Ireland, detention centres, child protection and welfare services, community residential centres and foster care services. And you'll see the numbers of those services that we have within Ireland. The resources we have to monitor and regulate those services is that we have 3 regional managers, so those services in different regions, who have 15 inspectors working for them. So as an indicator of some of the regulatory activity we carried out last year, you can see then the numbers of the inspections and that we carried out across all of those services, and then some of the notifications. And you'll see those same numbers identified there for the services with disabilities and for older persons. And it's interesting to see that, like for older person centres, we have 506 centres, but it delivers care to over 31,000 people. Whereas our disability services, we have over 1,000, almost 1,400 services, but yet there's only 9,000 registered places in that. And I suppose that's an indication of national policy to decongregate disability services, that they are living within our communities. So those services are smaller services. So that's just to give you a flavour of the health and social care services that we regulate and a little bit about HICWA. I'm going to hand you over now to Carol, who's going to talk about what we mean by self-monitoring.
So we've defined self-monitoring as the provider's ability to self-assess their own service against the regulations and standards to promote safe, good quality and an inclusive service. And I suppose what we have found all too often is that providers see the regulator as a quasi-auditor, and they wait for us to come out and identify the deficits before they take action. So by encouraging providers to continually self-monitor, it provides an assurance to us as a regulator that the provider is outcome focused for the benefit of the service users or the residents. But it also gives confidence to the residents and their families that the provider and staff are focused on continuous quality improvement. And we particularly see this with providers who are consistently demonstrating compliance with the regulations. They're not focused merely on meeting the requirements of the regulation, but they're constantly striving for continuous quality improvement. So we have a number of, sorry, Aileen, you're gone back into,
I'm gone back into
the mode of your slides. You need to duplicate.
Yeah, sorry, I'll fix that, Carl, while you're talking.
So in 2016, 2017, we undertook a complete review of our regulatory approach. And since then, we've introduced a number of tools and guidances to support self-assessment by providers. And these work alongside some of the statutory requirements that providers have. So similar to CQC, we have assessment judgment frameworks, and our assessment judgment frameworks are our anchor document, which we use to assess compliance with the regulations and standards. And we would have one for each set of regulations or standards because the ask of them is quite different. And the assessment judgment framework includes the regulation or the standard being assessed, or a combination of both for the cases of designated centres. The lines of inquiry to be explored in order to assess that compliance, and then the judgment descriptors that are applied to that level of compliance. And then alongside that assessment judgment framework, we also have guidance on the assessment for the designated centres. This is a key tool that our inspectors use, but we've also published it on the website in order to encourage providers to use it themselves to self-assess their service. So it clearly tells them what they are required to have in place, but it also signposts them to what good practice looks like, so meeting beyond the requirement of the regulation or the standard. There's also statutory notifications, and while there are two sets of notifications, one for registration and one for care and welfare or care and support, we really focus on the monitoring notifications, and they're the 3-day or quarterly notifications in relation to care and support or care and welfare. And they're notifications that the regulations require, and certain incidences or information that must be notified to the Chief Inspector, such as deaths, expected or unexpected, infectious disease, staff misconduct, serious injuries, abuse, or restrictive practice. And to support providers, we also produce guidance in relation to these notifications. But we don't just require the notification, we also require the provider to learn from the incidences that have occurred and to use that information to improve the quality of life for residents. We've also undertaken a research project, it's called the Lens Project, which has focused on learning from notifications. And we've made available a database of these notifications, which can be used for learning and research purposes, and that's available on our website. The regulations also require statutory reviews by providers. So there's an annual review required by the provider, and that must be aligned to the standards that are specific to those services. And we require that to be submitted to us at renewal of registration. And that's a standard request that we ask, but we can also ask for it at any other time during that cycle of registration. And we will also review it when we go out on inspection. And for centres for people with a disability, the provider is required to do a 6-monthly visit to that centre and produce a report of that visit. And we've produced a template for providers of what we would expect that they would conduct during that visit. And during times of escalated action with a provider, we will require this 6-monthly visit and report to be submitted to us. We also request information of providers, and we call these provider assurance reports. And that is where we receive information of concern, which either could be what we call unsolicited information, which could be from the public or a media article or a family or a friend, but also a notification that has been submitted to us. And in this case, we require the provider to undertake their own investigation, provide assurance to the Chief Inspector on the actions that they took or intend to take and what learning they intend to implement as a result of that. We can request this provider assurance at any time. And again, we've developed a template for providers to use to ensure that their investigation is aligned to either the regulations or the standards. Our compliance plan responses, then, that's sort of like an action plan that will be at the end of the inspection report. But we changed this when we did our complete review, because what we found was providers were only addressing the failings that were being identified. Now we ask the provider to look at their systems and look so that they could see how they're going to comply with the entirety of the regulation, rather than focusing on the specific failing that was identified on inspection. And we ask providers to tell us how they're going to change their systems to bring the centre back into compliance. And we can also request a compliance plan update in between the inspections. So as Aileen said, it's a minimum of 2 in a 3-year cycle. But by requesting an update on this compliance plan, providers can then tell us, and it keeps the compliance plan as a living document for the provider. And then we've also developed self-assessment tools, especially for new commencements, so where we're expanding our function, and also where for new registrations. So for providers looking to register a new centre, there's a self-assessment tool that they need to complete to make sure that they're actually ready for us to regulate their service, that they're ready for registration. And then providers are required to audit and review their own service. And we can look for these audits if we're concerned about a particular area, or we will review them on inspection. And then we've also developed thematic programs, which are quality improvement programs. And these are very much around self-assessment. So we develop an advisory group with representations from the providers and residents or advocacy groups. And we produce assessment judgment frameworks. But what's slightly different with this one is we produce a self-assessment questionnaire and a quality improvement plan template for providers to use. And while we might invite the provider at a particular time to partake in this program, we publish all of the tools at the beginning of the program and encourage providers to use them to self-assess their own service, and then continuously use them to identify improvements throughout the life cycle of that program and beyond. So we've seen some benefits and indeed some challenges to it. What we have found is that self-monitoring helps to empower providers and staff to take responsibility and accountability for their own service. And through that responsibility and accountability, improvements can be made and quality improvements driven. It supports better governance at a centre level and at a provider group level. It supports the provider's own assessment of compliance, which means they don't wait for us to come out to address their deficits. And that improves communication between us as a regulator and the provider. And staff feel confident in telling us the next time we go out doing an inspection, look at what we've done since the last time you have been here. And it gives greater clarity to providers as to what is expected of them. And then we, as a regulator, have greater confidence and assurance that this provider is capable and has the capacity to do what is required. But I suppose on the flip side of that, there is challenge. There's challenge from providers themselves that there isn't a regulatory remit for some of the tools that we have introduced. Providers have to have the knowledge and the capacity to be able to implement these self-assessment and self-monitoring tools. There is a perception of the public, of our policymakers, that self-regulation is not appropriate and that it has to be an independent regulation, which undermines the trust in the process. And with any process like this, it has to remain relevant and up to date, which can be resource intensive. Thank you.
Thank you very much, Carol and Eileen. It seems you have various tools and very structured instructions to use them. So it's very interesting. Let's see if we have any questions. Talia?
You mentioned that some of the tools are mandatory and some of them are voluntary, and you have guidance. Okay, you have some sort of guidance to providers how to fill these forms or tools. Do you do any training as well?
Yes, we would. So when we undertook the full review, we held a lot of sessions with providers. And when we introduce anything new, we will, well, actually, COVID has had its benefits in that the webinar system has come in place. We would have done a lot face-to-face, but we found we're able to reach providers much quickly through this webinar type model. So any quality improvement program comes with education. Any new guidance that we would issue out, we would do sessions with providers around it. And if we find that providers aren't using it correctly, then we will engage again with providers, or we'll tweak it if it's not working.
Thank you. Thank you. Thank you very much, Carol. So now we'll move to our next presenter, Dr. Hila Chaim-Zweig from the Ministry of Welfare and Social Affairs here in Israel. Hila, the floor is yours.
Hi, can you see this? Yeah, can you see the presentation?
Yes, we can see.
Hello to everybody. I am so anxious and excited about this opportunity. The last time that I met you, Dave, was in Jerusalem, and that was about the last time that I spoke in English. So my English is very rusty, and please excuse me if I get stuck. This is a great opportunity for us to learn, because we are in the journey for professionalizing our regulation. And the element of self-monitoring is a very important element of our regulation paradigm and our practical work. So this is very important for us, because we invest a lot of efforts, and I will soon present these efforts, but we invest a lot of efforts into this professionalization processes. So I would like to thank you so much for taking the time and sharing with us your knowledge and experience. And I would also like to thank Brokdale for supporting our efforts in many instances, and for arranging this session, and the representatives of the ministry, which are here, some of them from the unit that I belong to, and some of them are partners from the professional units. So thank you very much. I will present very quickly some words about the Ministry of Welfare and Social Services, who we are. So the ministry, most of the services in Israel are outsourced. There are some services which are directly provided by the state. For example, correctional services for youth or probation officers. But the other services are mostly outsourced or provided by the Department of Welfare in the municipality. The ministry also funds, except for providing the services, they also fund the services. They fund 75% of the services. The municipality funds the rest. They are in charge of outsourcing processes, setting standards, setting policy, developing programs. We are also responsible. We're in the ministry, and we're also responsible for the inspection processes. Our inspectors are also consultants of the services. So they have two hats, and they do both of them. The ministry is also in charge of registration and licensing, monitoring and assessing. And the scope of services is very wide. Services for senior citizens, people with disabilities, children, families, people with addiction, correctional services. It's a wide scope of services, all the welfare services in Israel. These are our roles. And a few more words about the social services in Israel. We know that about 16% of the Israeli citizens receive social services. During the last few decades, we have an increase in community services, a decrease in home care, in out-of-home care. And we have approximately 15,000 community services, which are centers. We have 256 welfare departments in municipalities, which we also regulate. And we have out-of-home care, different institutions, about 2,000. This is how we perceive regulation. We perceive regulation as beginning with policy and standard setting of services, continuing, and all these elements are the elements of the ministry. It continues with inspection, which is receiving a clear picture of how they implement these standards, continuing with consultation, which is a process which is intended to improve the standards of just a second, I need to find the word in Hebrew and then say it in English. It's a process which is intended to improve the quality of the service, sometimes enforcement either by headquarters or by the inspectors, and it's supposed to be a circle. It's supposed to be a circle because we know that the data which the inspectors gather from their inspections is supposed to be to come back to policy standards and setting and to the update of these policies. So this is one of the focuses, the main focuses at this period is seeing how all the different arms of the ministry use the data in order to do their job. Okay, a few words about our inspectors. Our inspectors are mainly social workers. There's a large caseload especially for community inspectors. We have 210 inspectors. They have a caseload of between 70 and 100 social services. They also have, in addition, they have the welfare departments in the municipalities that they inspect. And we have also different inspectors for out-of-home services. We have about 60 inspectors, which have a caseload of between 12 and 60 social services. Not all of our inspectors are directly inspect, so this is why the numbers are not one for one. What we know is that what we saw in the last few years is that there is a big increase in the number of services, but there wasn't a great significant increase in the number of inspectors, which causes burden and burnout from our inspectors, which they say that they have a lot of work, and we can see that they do not have time to do anything else. During this year, we are gradually combining professional inspectors for complementary fields, like engineers for inspecting structure safety, or nurses for medical care, or nutrition. So this is, we know that an inspector who is a social worker needs to be, to have assistance in fields that are not in his area. And in this year, we are beginning gradually to combine them in their, in the inspection plans. Okay. As I said in the beginning, we are conducting a lot of processes for the professionalization. This is not a word that comes out very easily. So we're trying to professionalize our regulatory role in a number of ways. First of all, we moved from a distinct regulation of each sector to forming a central policy for regulation. In the past, each service had a different, you can say even a different definition of what an inspector does. And now we have one main definition with different tools. We're developing and assimilating, and we're in the process. In the last 4.5 years, this is what we've done. And this meeting is very important for us to see how the element of self-monitoring is interacting and how it will be combined with our model of inspection, which the inspectors do. In the last years, we're also had many organizational, all these very long words, organizational changes we had with the headquarters, a clear definition of what the headquarters does and a clear definition of what the districts and the regional inspectors do. And that changed a lot of how we work. We are now trying to see how, I'll put that aside, we have implemented many monitoring and inspection methods, a lot of technical systems, a lot of tools, technological tools for the inspectors. And we are putting a focus, as I said before, on sharing information, first of all, in office, with ourselves, with headquarters, learning from what is brought from the inspectors, from the information there in order to change their policy or develop new programs. That's first of all, and also with the public. We are now beginning gradually plan and then the implementation. It will begin in the next few months of publishing inspection reports on the website. This is a huge change for us. We have also begun professional training with the help of Brokdale. We have begun. We have a history of risk assessment, but we're professionalizing this field with a method and the implication of this method into the inspection program. We are developing quality measures, both generically and specific ones. And I would like to say, if I didn't say before, because of being so anxious about talking in English, Brokdale is helping us a lot also with these quality measures. Their help is priceless. So I would like to say also thank you for that, Talia and Hila. And all these are different ways for us to professionalize the role of regulation of the ministry. And now we will get to the self-monitoring, which should be combined in these processes. And we should draw this model of how we will combine it, how the inspectors will use it, and in what kind of plans, how it will motivate, how it will change the way that we work. A few words about our self-assessment, self-monitoring. We're trying to find the right word. We haven't yet. Our current definition is self-assessment or monitoring of services according to standards and requirements. It is also the direct reporting of gaps and of irregular events. We see it as very important to us for these because it helps self-reflect the services, the providers. It will strengthen the responsibility and quality assurance of the service providers themselves. It will also, the data will support our regulation program. We don't know exactly how, but it will support it and we know it. It will prioritize the inspectors' visits, their method, either from afar or their frequency. And it will make more accurate the activities that we choose to conduct. During the years, we have a few means of self-monitoring have developed. These are a few of them, the RAF method. We have also different kinds of methods. Since the COVID, since Corona, we used self-reports which were sent to the services. They were mandatory. All of these examples are mandatory except for the ESO. And we sent self-reports and self-report forms to the services and received information from them and from the local departments about illness, about quarantine, about means of intervention, about their needs. And we saw this was a great opportunity to see how important it is for us to receive this information, direct information from them, because it gave the inspector a better focus of what they need to do. And this is also the background for this meeting and for our awakening and our striving to combine self-monitoring in our processes. So what have we learned? Benefits, challenges. First of all, that's very important and it has great value. We understand that it is necessary to form a comprehensive model. It has to be held. We have to understand what the inspector does and how it will be influenced by self-monitoring. So we need a comprehensive model in theory and in practice, in order for us to combine it with our plans, our regulatory plans. We need to form a conceptual and practical framework. We need to find the accurate term. We think with our experience that it should be mandatory with periodic times set ahead that we will receive self-monitoring forms or in other means information from the services, including sanctions. We as a state have sanctions that we can use either by law or by the michraz. How do you say michraz? The contract we have with the outsourced provider. So we do have sanctions that we can use, and we think that that would be a clever thing to do, not to make it voluntary. We also thought of having sample inspections of self-monitoring to see how accurate they are. We need to develop methods and technological systems that, on one hand, enhance the service provider's responsibility for quality assurance. It's a state of mind that we want to assimilate, that it's their responsibility for quality assurance, and this is one of the tools. And also technological systems that alert the services when, if they did not, if there is a gap between the standards and there is a certain situation, if they did not report to us, and also facilitate the inspectors. What we saw in the forms that we sent during the beginning time of the corona was that inspectors had to run after these services, and most of the time was spent on that. And this is not something that we want, so we need a technological system to assist that. And we also want to develop tools that for the investigator, for people in the office that have a regulatory role, that concentrate data. This is one of the data. This is an important part of the data, but it's not everything. But we need tools that will give us a picture of what is going on in the services with this element that will complete a whole picture. So we need also these kind of tools. And at the end, when I stop talking for about 15 minutes, the English comes out better than in the beginning. So thank you for that.
Thank you very much, Hila. Your English is perfect. You don't have to apologize. So thank you for your presentation. I'm turning to you, panelists. If you have any question to Hila, any question on her presentation, this is an opportunity to ask. Or maybe you can ask each other anything that you want to know more about. Yes, Carol?
A question. Oh, sorry.
I'm just very interested in the idea of a one approach to regulation. I suppose we're advocating for one social care policy because we see that a disjointed approach to regulation where we have different sets of regulations with different sets of standards, with potentially different enforcement powers, and a whole new act coming for home care. How did you move to having a one approach?
Our unit, you're asking me, right, Carol?
Yes, please, sorry.
Our unit, okay. Initially, about 4 years ago, every service had a different policy regarding that service. That is still existing. If I have a center for the elderly, I have the policy how to implicate or run this service. But the regulatory, like inspection plan and inspection tools, inspection systems are common. We have the same inspection tools. They're
adapted.
They're adapted to each service, but it's the same system built on the same definition of what an inspector does, but it is adapted to the differences in each service. In the past, I will explain a bit more. In the past, some inspectors were only consultants. They did not have to inspect, okay? They did not have to make methodological inspections of the services. But now everybody, all the inspectors know that they serve also as a consultant, and they have an inspection plan. So this is what is common, but there are differences in the tools themselves according to the different policies of each service. I don't know if I'm clear in my answer.
Oh, that's perfect. Thank you.
Okay, thank you.
Is there any, we have time for one more question, if anyone?
Maybe if I could come in just very briefly to ask yes, basically it's a question for everybody, for colleagues from Israel, from Ireland and England. I wonder, how do you feel that quality improvement is changing? In the sense, I have the impression looking over the years that at the beginning was a lot about inspection, but we're moving forward, from the inspection into more helping, into improving services. And how do you think, how do you work, and how do you feel the next steps are in terms of working with local with authorities on the one hand, with providers on the other, to make sure that everyone is sort of on the same page, I might say, rather than from a top-down approach into more of a collaborative way of working towards quality improvement?
I don't mind going first, if that's okay.
Yes, please.
I mean, a part of that simpler and rationalized structure for our framework is about giving better outputs to providers so they can drive their own improvement. So I mentioned in my presentation that we have these really lengthy narrative reports, and it's quite difficult to disentangle and understand the key headlines. We do have ratings, but they're quite a high level. So what we'll do for each of those 32 quality commitments, there will be essentially a rating there as well. So a provider can see where their strengths are and where their weaknesses might be. And there's another level of detail below that, which is those 6 evidence categories. We won't publish our ratings of those, but they will also have a score. So there's essentially 3 layers of structured data for them to really understand, oh, okay, I can see my safeguarding is an area of weakness, and I can see that it's about policies and procedures, or it's about, this is drawn from what partners in the system have said, that they can really kind of work on those areas in a more structured way. So we're quite optimistic about that as being a helpful tool. Alongside that, though, CQC has always struggled a little bit with what's our role in improvement. Again, kind of a philosophical challenge. Are we marking our own homework if we tell the provider too much? And we have a very inconsistent approach to this across different inspectors. Some like to be a coach, and kind of really help, and others don't. And given that these are mainly private businesses, we do need to get that consistency there. So it's something we're exploring now, actually, as part of our strategy. What is our role in improvement? How do we line up with our partners who also have a clear role in improvement? How do we all come together to help providers more than we perhaps are at the moment? And what's appropriate? So lots of questions and not many answers at the moment.
I might come in as well, Jake, because we struggle with that very point you've just made. I suppose we're slightly unique in that we have a standard setting function within HICPA. So, and some of what they're doing is about developing tools to implement the standards. But that's, I suppose, one of the reasons we developed this quality improvement approach against the standards, where we take a particular focus. So we've looked at restrictive practice, and we've developed a whole thematic program around restrictive practice. COVID interrupted that. We intend to develop more programs in that vein. So we're trying to do it in bite-sized chunks as opposed to hit the whole of quality improvement. But I suppose, and you made the point at the very beginning, it's about transparency. If we give the provider enough tools to be able to do it themselves, and that the quality is actually driven from the service with our direction as opposed to us driving the quality, I think that's the approach we're trying to take.
Mm-hmm. Thank you, Carol. Thank you. And we are running out of time. And I think we are here with a lot of answers, but a lot of questions too. I want to hand over to Unit to wrap up this meeting, but I want to really thank all of you, all representatives and participants being here today, taking your time. We had about 60 participants here from many areas, researchers, people from the government, people from inspectors, and people, service providers. That was very nice to see all these participants. We will send you all a summary of this meeting along with the presentations, if it's okay for you to share. And if you or the participants have any thoughts or questions, please send us a mail. We're researchers. We're looking for as much questions as possible. This is our role in our day-to-day role. So now I would like to invite Dr. Yonit Yakubovich, the head of the quality group here in MJB, to wrap up this meeting. Yonit, the floor is yours. Yonit, you are on mute.
Now it's okay. So thank you, Hila. And I'm really very excited. And I would like to thank you all, the panel partners and the entities for they made this inspired webinar. So in 1675, Newton wrote to Hawke, and he said that if I kept a sight further than others, it was only because I stood on the shoulders of giants. So as researchers, we know that the base of understanding our knowledge is built on the foundation of the people that were here before us. So we all enjoyed the great opportunity for a peer learning that combine researchers and participants for several countries. This type of cooperation propose our understanding on key issues and enable mutual learning and progress. Self-monitoring, as we heard, in the regulation of self-services, emphasizes the services providers' own responsibility on their actions and the quality of the services they provide and the safety of the services users. In this webinar, we were able to address important questions, discussing these questions and improving and important to advance our knowledge and expertise, and hopefully advantage really in which services users received the best service as possible. The difference between countries and the different regulation system allow us all to learn a lot from others and enrich our research and enrich our project. Part of our job is to contact organizations. In our daily work, we are in touch with various organizations all over the world, and we are happy to serve as a coordinator, to get people together and head activities like our webinar today. This is what we do every day. And this is why my group in MGB, the quality group, is really doing all the time. And we are very glad that you took part in this journey with us in the past hour and a half. I hope to invite you all to more events such as this in the future and encourage you all to share with us ideas and or include us in your activities or all what you are doing. So thank you very much, and back to you, Hila.
So thank you, Yonit. Thank you for these words, kind words and warm words. I also want to thank all my team who worked very hard to make this happen. Talia, Tal, Lior, Merav, and Ellen. We all wanted to this be well and successful. And I think we really have a lot of food for thought for the next coming weeks. Thank you all again, and I hope to see you soon.
Thank you, everybody. I would like to just say thank you very much, everybody who presented. It was so important, and we will receive the presentations and learn from them also. I would really like it if we could continue consulting with you with specific questions, which we will have and have arisen due to this presentation in the future. So I would like very much to thank you for the present and for the future, which we will very much like to learn from your experience. So thank you very much.
Thank you, Hila. So see you soon.
And be well.
Bye.
Thank you very much. Bye-bye.
Be well. Take care, all of